Hi, I'm Bill Gradisher from Northwestern University in Chicago.
And I'm Hope Rugo from the University of California, San Francisco Comprehensive Cancer Center.
And we were going to comment on several of the presentations that we thought were particularly interesting and potentially important that you should learn about that may have some impact on how you practice in the coming weeks and months. And I guess to start out with, I'll just comment on the ATOM trial. The ATOM trial was another effort to try and evaluate the optimal duration of tamoxifen therapy. And just as a quick backdrop, many years ago, it was established largely based on an NSABP study that longer durations than 5 years did not confer benefit with tamoxifen. We more recently heard data from the ATLAS trial, which again was a very long trial that has been incubating for some time, suggesting that 10 years may confer an added benefit to 5 years of tamoxifen therapy. And at this meeting, we heard the companion study, the ATOM trial, which is also another effort to look at longer durations of tamoxifen versus 5. And it was very complementary to what we heard in the ATLAS trial, that being that longer durations appear to be better than 5 years of tamoxifen. And I suppose the important caveats is this may apply to only certain subsets of patients. It doesn't have any implications for AI therapy duration. And I think specifically where we would say this might have the greatest benefit is in younger women who may have still remain premenopausal, who have sufficiently high risk where we want to do something else and an AI isn't an option. And I think in other areas it's not as crystal clear. I don't know what your takeaway was.
Yeah, I agree. I mean, I thought the ATOM trial, actually more of the patients had ER positive as a known entity than in the ATLAS trial, so that's helpful. There, in the presentation they showed how many, thousands and thousands of women have been involved in these trials. It's clear that longer duration hormone therapy is better. I think we know that answer. Interestingly, if you continue hormone therapy past 5 years with tamoxifen, specifically, you have a higher rate of endometrial cancer, risk of getting it, and a higher mortality from endometrial cancer. Those numbers were very small compared to the risk of dying of breast cancer. And in this ATOM trial, they showed an improvement in, pretty much an improvement in survival. So I agree with you. I think that younger women are going to be at much lower risk for endometrial cancer, so that's a better choice. But also for postmenopausal women who are intolerant of AIs but have higher risk disease, that means that they could switch back and forth to tamoxifen. I just think that we need to be monitoring for endometrial cancer with ultrasounds and careful follow-up in women who are taking longer duration tamoxifen because it's clearly a risk. I also think that everybody doesn't need 10 years of hormone therapy. It's women who have higher risk disease and at 5 years have a higher residual risk.
Okay. You want to comment on Bolero?
Yeah, so the data from Bolero 3 was presented by Ruth O'Regan, and this study actually looked at the mTOR inhibitor everolimus in patients who had pre-treated HER2-positive metastatic breast cancer, previously treated with trastuzumab and a taxane. Patients received vinorelbine as a continuous dosing at 25 per meter squared without a break, meaning there was a fair amount of hematologic toxicity, and trastuzumab with either placebo or everolimus. Because they'd already tested this in a previous smaller trial, they knew that you couldn't give 10 milligrams of everolimus, so 5 milligrams was a dose. And actually, in Bolero 1, the first-line trial that we'll hear sometime later, maybe next year, with paclitaxel, they're able to give 10 milligrams, which is the exemestane and everolimus dose. The progression-free survival, which was the primary endpoint, was longer in patients receiving everolimus, so also was toxicity. There isn't survival data yet. There's a little delta, but it's way too early in terms of events. And the difference in PFS was about 1.5 months. So there's a lot of discussion about where this is going to fall with pertuzumab and TDM1, and I think in the late line therapy area for HER2-positive diseases where it's likely to fall now.
Yeah, and I think from the discussion of many people, including the sponsors of the trial, they're really positioning this as a third-line therapy, first with the triplet of pertuzumab, trastuzumab, and a taxane being first, then TDM1, and then we have a variety of different permutations of third line and beyond, and this may fit in there. The other areas I think that were interesting, there was a precog study presented just a few minutes ago that looked at patients with triple negative disease and BRCA-induced mutation tumors and reevaluated the combination of gemcitabine, gemcitabine carboplatin and the PARP inhibitor and nipirib as a preoperative investigation to determine what the activity of the drug was. What's interesting about this is they did a number of ancillary studies to try and characterize the subtypes of breast cancer, looking at the intrinsic subtypes as well as the Vanderbilt assays to try and subset so-called triple-negative breast cancer. And then finally, and perhaps what came out as most important and effective, was looking at an assay looking at homologous repair defects, an assay that's being developed by Myriad. And what they found was that in patients who had that HRD defect, the likelihood of developing a complete pathologic complete remission was highest. Similarly, if you were triple negative, you had a mutation in BRCA1 or 2, the likelihood of benefiting was clearly the highest. But the key thing, I think, was looking at that HRD assay, which seemed to be the most useful. So again, the PARP inhibitors by no stretch are dead. I think we're just acquiring additional information, trying to figure out where they're best used. What did you take away?
The thing that's interesting about this study is done very close to where I work, and so I referred patients with triple-negative disease, in particular those with BRCA mutations, down for that trial run by Melinda Telly, is several things. One, that was very involved in the phase 3 trial with the nipirib, and this drug is clearly not a PARP inhibitor. So I think the study itself has no relevance really to the study of PARP inhibitors, except for the fact, as you mentioned, that maybe this HRD assay, homologous recombination deficiency, which is really measuring loss of heterozygosity and the sort of looking at where the regimen is, where the DNA is that helps you with DNA repair, homologous recombination. And if you don't have it and you don't have a BRCA mutation, maybe you're more sensitive to this combination chemotherapy. So if a nipirib isn't a PARP inhibitor, what does that really mean for us? And it means that you may be able to find the group of patients who have triple-negative breast cancer that's sporadic, who have disease most sensitive to DNA damage. So that regimen, gem-carbo, that's not a particularly used regimen. We don't give it in early-stage breast cancer. We don't know what the long-term outcome is. But what was interesting was that about a third of the patients had a pathologic complete response in breast and node, which is very similar to what we've seen with other regimens. So I think the idea of trying to predict who could benefit from DNA damaging agents may help us predict if there is a population of patients who have triple negative disease without a BRCA mutation who might be sensitive to this approach and treatment. So I thought that was very, very interesting. The other thing I think just to mention about our trial is it was 6 cycles of gem-carbo. It was weekly, 2 weeks on, 1 week off, the way we used it in the metastatic nipirib trial. And hair loss is really not seen. Toxicity other than liver enzyme abnormalities in some patients, some rash, some thrombocytopenia. Other than that, there wasn't a lot of toxicity. I mean, you don't really get a lot of nausea and vomiting, so no neuropathy really to speak of. So it's an interesting regimen. Where we'll go with this in terms of trying to figure out outcome remains to be seen. I think it leads into nicely the large GEPAR-6 trial, which was the 6th trial of the GEPAR group in Germany that Günter von Minkwitz presented. And there they had a very complicated chemotherapy regimen, which they always have, where they included patients with triple-negative breast cancer and with HER2-positive breast cancer. And this was a phase 2 trial. So altogether, they only had a little under 600 patients and less that finished everything. So it is not a huge trial. But the regimen was patients got paclitaxel and then a low dose of a non-pegylated liposomal doxorubicin called Myoset that they have in Europe, a low dose given weekly. And then they gave it for 18 weeks, so it was a longer course than we usually give. And patients were randomized to receive carboplatin or not. And all the patients who had triple-negative breast cancer received bevacizumab. All the patients who had HER2-positive breast cancer received trastuzumab and a low dose of lapatinib, 750. My key takeaway from that, and I'm interested in your thoughts, is that the patients who received carboplatin had a markedly better pathologic complete response rate than those who did not. And if you figure bevacizumab is a constant, so we could maybe not look at that, and they had previously shown that bevacizumab improves PCR rates. They saw a 20% improvement in pathologic CR rate if you included patients with in situ disease and those who received carboplatin. And they started with an AUC of 2, but you can't give that continuously, we know that, so they dropped it to 1.5. But I'm very interested in that in this group of patients and going back and trying to figure out if we understand the subset that benefits from that treatment.
Yeah, I agree. I mean, the first observation was an incredibly complicated regimen, but I think the key observation, which you pointed out, is the contribution of the platinum. And the discussant really sort of reviewed the accumulating information that we have, that the platinums, which we had more or less disbanded many years ago, clearly appear to have a role, at least in this subset of breast cancer, in trying to refine what that drug or that class of drugs should be partnered with, particularly in these so-called triple-negative breast cancers or BRCA-induced breast cancers, are really going to be the subject of a lot of the work going forward. I wanted to make a comment about one of the other randomized trials, adjuvant trials, that was presented, or I should say represented. Larry Shulman presented the updated the CLGB trial previously reported, which was looking at AC versus paclitaxel in node-negative patients, and there were a couple of questions. Obviously, the direct comparison between those two regimens, but also the duration, 6 versus 4 cycles. And the latter had been previously presented, suggesting that longer durations of either of the regimens was not better, but now a direct comparison of the two suggests that AC remains the superior regimen in terms of reducing the risk of recurrence. And of course, the hope was that we could get rid of the anthracycline because it is associated with some myelodysplasia, the well-known cardiac side effects. But despite those findings, it was also found in this report that paclitaxel was not the equivalent of AC. So I think the takeaway message from that is certainly a weekly schedule or every other weekly schedule, as the trial was modified to a dose-dense sort of Taxol dosing schedule, was not the equivalent of AC. How that fits in with today's treatments, where we don't typically use AC, we don't typically use T alone, is less clear, but this was nevertheless informative, and certainly paclitaxel is not a substitute for AC if you were doing that.
And it's interesting because one of the comments I think was really important, that cyclophosphamide in and of itself is very important, and now we're using more of a docetaxel cyclophosphamide regimen, and that's the NSABP trial, so we're going to have to wait to see whether or not that's equivalent to an anthracycline-based regimen moving forward. Clearly, anthracycline-based regimens have some toxicity. So the last trial that was presented actually in the oral sessions on Monday was the SWOG 0221 trial by Tom Budd, presented that. And that trial actually looked at an interesting set of regimens, one of which I wasn't very fond of. I actually discussed a few years ago. One, they looked at a metronomic style dosing of doxorubicin and cyclophosphamide weekly regimen with growth factor support all the days but your day of chemo, and then versus dose dense. And they had already shown that it wasn't better to give the weekly regimen, and that actually got a little bit more leukemia, which they didn't mention today. So they stopped that arm and they just continued the dose dense AC. And then they went and looked at the weekly T versus dose dense T, where the T is paclitaxel. And of note, it was weekly T for 12 cycles, and the dose dense was times 6, so that it would be as long. And they showed that they were identical, which was, I think, pretty much in what we thought. I mean, I don't think that when you extend out the duration and you're giving drug all the time, it's kind of reasonable that in all comers it's going to be about the same result. There was no subset that seemed to particularly benefit more or less from one regimen. What they did show was that the toxicity is different. So the group of patients who got dose-dense paclitaxel had less hematologic toxicity than the weekly paclitaxel. A little counterintuitive, but of course they did get pegfilgrastim. The patients who got weekly paclitaxel versus dose-dense had less musculoskeletal complaints and less grade 3 neuropathy. So the point was made afterwards is that all of these are dose-intensive regimens, and they all work really well. And now we could actually say to a patient, it's okay to get dose dense if you live far away and you want to come every 2 weeks. We don't know how many numbers we should give. Maybe 4 is equivalent to 6. You could read that into the other trial. and that weekly would be good in terms of reducing peripheral neuropathy. My take on it is, the thing that would bother me the most would be peripheral neuropathy, because that's what's going to affect, your typing and your keyboarding and all the things we do all the time. So weekly paclitaxel may be a better choice for many women. Lastly, there was a lot of things going on at this meeting about biomarkers. One interesting presentation from Emily Anderson looking at subsets of triple-negative disease based on the Vanderbilt 7 subtypes. Fascinating, absolutely fascinating. Groups that have more PCR, less PCR, and better outcome even without PCR, like an androgen receptor-like triple-negative group. Really interesting, and I think this will be something that we incorporate in some way or another into our practice in the next few years. It's not tomorrow, but this is exciting to me, that maybe now we can parse out triple-negative disease into a way that will really help us treat women more effectively, find the groups that do poorly, this basal-like 2, and then treat those women with novel therapeutics. So that's actually was very exciting to me. And in the Bolero 2, Gabriel Hortabaji, on the behalf of our group, presented data on biomarkers that Jose Baselga had initially presented at AACR. Also very exciting, may lead us towards being able to understand which women with ER-positive disease benefit more from agents that target PI3 kinase and mTOR.
From ASCO 2013, this is Dr. Bill Gradisher.
And Dr. Hope Rugo. Thanks for listening.